And welcome everyone who is joining the session.
Yeah, I would like to describe briefly what we're doing in terms of cell therapy. We are focusing on graft versus host disease, which is an immune response to patients that receive bone marrow transplantation for lymphomas and leukemias. For these patients, the cells that they are receiving, which are from individuals that are not related, can potentially damage their organs. And this is a very serious situation where it can even lead to death. So what we have developed, working very closely with the scientists at the Karolinska Institute in Stockholm, is a way to characterize and isolate cells from the decidua, which is in the placenta of pregnant women once they deliver. And we use these cells to regulate the way these cells that are produced in the graft versus host disease are able to manage this disease. So to be able to do that, we obviously need to understand very well what's the situation of each patient. So we need to personalize the moment that we provide these cells, which are called DSCs, Decidua Stroma Cells. They're a type of stem cells, and also understand how the patient is responding to them. So that's the personalization that is absolutely needed here. So we want to make sure that we understand at which point we are able to deliver these cells and how, again, the patients are going to respond to them. And we're using to understand that the experience that has been already observed for a long period of time, about 4 years in Karolinska, where they have already treated a number of patients. We have discussed these results with the agency in the United States, with FDA, and they agree with us to move forward with a phase 2b study. So we indeed need to take a very thorough look into everything that has been already done by these patients, being able to produce this off-the-shelf, these allogeneic type of cells, and ensuring that we get a kind of consistent response. Something I would like to share with all of you, because we're talking here about the importance of clinical drug supply, is that we need to also ensure that there is a batch-to-batch consistency. We are still in the process of having this tech transfer from Karolinska Institute to our laboratories in the San Francisco Bay Area, and then to LA for City of Hope, which has a number of suites able to produce these cells in a very consistent manner. We are developing that. So we are in the process of ensuring that we have a batch-to-batch consistency so that the cells can be obtained from different mothers, and these Decidua Stroma cells, despite coming from different individuals, have the same effect. So again, a different type of approach. This type is allogeneic, off the shelf, but that also requires a different type of approach to cell therapy. So I think that we are already in the right track. So you know that CAR-T is an area, for instance, where you need a very specialized type of approach. Is basically taking the cells of the patients, manipulating them, engineering them, and then re-injecting them with certain surface proteins that are going to do the job, either looking for CD19 or CD20. What people are now starting to look at in this space, and I'm expanding a little bit what I'm talking about, CAR-Ts, is going into allogeneic, which are going to be useful for solid tumors. And there are a number of companies like Allogene that are trying to do exactly that. We are not there. I haven't seen results that are solid enough to be able to really produce some results in the at least near term. But that's something that I think we're on track, and it's absolutely critical, because also the cost associated with these autologous cell therapies is very high and requires patients being practically assessed and treated one by one, which has advantages, but also has costs associated to that.
Okay, thanks, Oscar. And Doug, did you want to add anything? And Oscar, anything to add?
Yeah, so one advantage that we have with the regulators is that the FDA has developed guidance documents to help the industry identify and qualify biomarkers for safety and efficacy of pharmacodynamic response, drug selection, disease severity, progression, and prognosis. So I think we are in a very good place, and they are ready to help us. In our case, for instance, I can give you a situation that just came up in the past few months. We were ready for a second-line type of therapy for a steroid refractory graft versus host disease. And there was a new situation where now we have ruxolitinib, which is Jakafi, is 2 pills a day for a number of weeks. And that has become now de facto a second-line therapy. So we will need now to start working on a third-line therapy first before going potentially to a second line. And this is a kind of discussion that we need with the agency. We also will need to ensure that we identify surrogate markers. And what we are doing is that we're bringing some of the experts in the field to define criteria that are going to identify patients that really fail to this second line therapy. So as you can see, there are always moving targets. You have to keep an eye on the industry and competition. And I think at the end of the day, the agency is going to be helpful and ready to support us.
Hi there. Thank you so much for a wonderful session. We have 2 questions we have to get to very quickly. If you look at the right side of the screen, the first one is from Ronnie Renfirm. Has the panel experienced a change of perspective on in vitro diagnostics for gene therapy programs more recently? Just like 30-second response to that question.
Yeah, I guess this is for me. We have also a gene therapy program. I must say the answer is yes. There is a lot of work going on right now on understanding and working with surrogate biomarkers. In our case, for instance, gene therapy for hemophilia A, we need to understand how factor VIII is produced, the translation from the mRNA to the protein, and how we are able to see if that protein is secreted. So we're working on that. There is something called unfolded protein response, which is a way to see if the hepatocyte, which is a kind of biofactory for factor VIII, is working or not. So yes, there is a lot going on in that space.
Okay. And then lastly, there is a question, it's quite a long question, but do you see similar innovative approaches to optimize future access and perhaps improved outcomes for your cell therapy platforms in non-Japan regions?
Doug, maybe you want to take that. It's about heart failure. So.
Yeah, I'll take a shot at it. The Japanese have certainly been the most aggressive, I would say, or innovative from a regulatory standpoint as it relates to cell therapy, creating pathways that are sort of, I like to call them the RMAT designation on steroids, with really very fluid access to regulators to discuss ways forward. And I think FDA has taken some of those cues and tried to make similar changes. But I think it's I would say the jury's still out on some of these heart failure cell therapies, and so I think we have to wait and see what the actual clinical data is before FDA is going to sign on to replicating any of the approaches in other regulatory jurisdictions.
Okay. I want to thank you all so very, very much.